Hey everybody, we're going to go through just a quick overview of the renal system to help you review as you get ready for things. This is originally a 4-part lecture, so you'll see part 1, 2, 3, and 4. That's fine, don't worry too much about it. And I'll just kind of go through things. Any questions, just feel free to email me. So overall, we're going to talk about a couple different things here. The biggest end product of metabolism is urea. The renal system also produces uric acid, creatinine, and the end products, they're the end products of the hemoglobin breakdown. This process is overall known as tubular secretion. You need to know that the kidneys service the retention area for nutrients, which is known as tubular reabsorption, which is movement back into the blood from the renal tubule. For example, glucose and amino acid. The kidneys play a vital role in the secretion of the hormones renin, erythropoietin, and the active form of vitamin D. They also metabolize hormones, including insulin. They serve to remove foreign chemicals from the blood, including pesticides, food additives, drugs, and metabolites. The essential functions of the kidneys include glomerular filtration, tubular reabsorption, and tubular secretion. The normal GFR is about 125 mLs per minute, and tubular secretions, the big movement is urea, and then it rests. So remember, urea is first, and then it rests. Everything else comes after that. And the goal is to maintain adequate hydration and renal perfusion. Quick overview of the kidneys. The right's lower than the left due to the presence of the liver, so if you're looking at a picture, just keep in mind that's why it's offset a little bit. The nerves from the renal plexus are vasomotor. The renal fascia anchors the kidney to the abdominal wall and the surrounding fascia. Just another view of the kidney. Any of the slides where I don't really talk about stuff, just take a quick mental snapshot of all these pictures because you might see this on your NCE. You need to know the nephron's the basic unit of the filtering system. There's several key components, including 1 to 1.2 million units called the nephrons. Other components include the glomerulus and the renal tubule. The tubule system is where the ultrafiltrate is converted to urine. Glomerular capillaries are composed of tufts and jet into the Bowman's capsules, which provide a larger surface area for filtration. Blood flow to the glomerulus is provided by a single efferent arteriole and drained by a single efferent arteriole. Glomerular filtration pressure is about 60% of MAP, so keep in mind that's why we tend to take that hit when our blood pressures drop. 65 to 75% of the ultrafiltrate is absorbed back into the proximal tubule, and the major function of the proximal tubule is that reabsorption of sodium back into the blood, followed by water, sodium chloride, and glucose. The loop of Henle is responsible for maintaining a hypertonic medullary interstitium. Again, keep this one in mind. The collecting tube. So the collecting tubule is known for its concentrating ability. If you have an increased amount of ADH, antidiuretic hormone, the tubule becomes increasingly permeable, which decreases your urinary output. Decrease of ADH increases urinary output. Need to know that the juxtaglomerular cells contain renin or are innervated by the sympathetic nervous system. The major function of the juxtaglomerular cells is to secrete renin. Renin is then released into the bloodstream from the juxtaglomerular cells. It acts on the angiotensin and the liver to form angiotensin 1. 3 main reasons you release renin: beta-adrenergic sympathetic stimulation, changes in the afferent arterial wall pressure, and changes in the chloride flow past the macular densa. Renal function is intimately related to renal blood flow. We usually aim for about a half ml per kilogram per hour. If your patient's on bypass, we usually try and increase that to 1 ml per kilogram per hour. And if we increase renal blood flow, we will also increase our oxygen consumption, so keep that in mind. And you need to know that about 20 to 25% of total cardiac output goes through both kidneys. Renal blood flow is about 1,200 milliliters per minute. And the blood flow is renal artery to the segmental arteries, to the interlobar arteries, to the arcuate arteries, and back into the interlobar arteries. Veins are the same coming out into the pelvic ring and to the inferior vena cava. Intrinsic regulation of blood flow occurs between MAPs of 80 and 180. Outside of those, it's pressure dependent. Renal blood flow is decreased at MAPs below 70, so keep in mind you got to keep that pressure up. Glomerular filtration generally ceases at a MAP less than 40 to 50. Tubuoglomerular balance is a feedback loop that tells the GF to speed up or slow down. Hormonal regulation results in angiotensin II, epi, and norepi, affecting the different afferent arterial tone. Increase in renal vascular resistance decreases renal blood flow. Neuronal regulation results in SNS reduction in renal blood flow, kind of a stress response. The type of surgical procedure, fluid administration, pre-existing renal function, all affect anesthetic or all anesthetic effects on the kidneys. Intra-op decreases in renal blood flow, GFR, sodium excretion, and renal blood flow are all reversible. More decreases are associated with general anesthetics. However, a sympathomemectomy that you would see with regional anesthesia may worsen things as well. Effects can be partially overcome by adequate intravascular volume and a normal blood pressure. Results from light anesthesia, intense surgical stimulation, and anesthesia-induced circulatory restriction. The endocrine effects of anesthesia result in diuretic phase later on down the line. So you know that those patients are going to pee for a couple of days heavily after surgery, especially if we flooded them. Mannitol works in the proximal tubule. It limits water reabsorption that follows sodium reabsorption. Acute reduction in intraocular pressure comes from mannitol. IV dose is generally 0.25 to 1 gram per kilogram. Side effects, it initially increases the intravascular volume, then decreases it. You get transient hyponatremia, reduction in hemoglobin concentration. Loop diuretics used in edematous states may be used for acute oliguria intraoperatively. And potassium-sparing diuretics may result in hyperkalemia in patients with beta blockers or pre-existing hyperkalemia. Three big risk factors are predicting the incidence of post-op renal failure or pre-existing disease, CHF, and advanced age. The greatest renal derangements caused by abnormalities of glomerular function. Fortunately, it also is the easiest to detect, and the most accurate lab test for determining renal function is creatinine clearance. Ammonia is produced from the deanimation of protein. The ammonia is converted to urea, which will affect the BUN. The BUN is inversely related to the glomerular function. You need to know that normal BUN is 10 to 20 milligrams per deciliter. Elevations may result from decreases in GFR or increases in protein catabolism. Normal GFR, increased BUN, start thinking about dehydration. BUN level is a late indicator of renal disease, and it doesn't decrease, and generally your GFR has already dropped by 50%, and think about them being increased in a febrile state. You need to know that serum creatinine is directly related to muscle mass and inversely related to glomerular filtration. Good range is 0.7 to 1.5 for concentration. Each doubling of your creatinine is a reduction in GFR of about 50%. GFR also declines with increasing age, yet serum creatinine remains relatively normal in age. That's due to the decrease in the muscle mass found in the elderly. Large meat meals, Tagamet, and increases in ketoacidosis increase serum levels without a change in GFR. The BUN to creatinine ratio greater than 15 to 1 are generally seen with volume depletion, decreased tubular flow, obstructive uropathies, and increases in protein catabolism. Just remember this slide right here with those values on it. Specific gravity is related to urine osmo, and it's indicative of renal concentrating ability. Normal specific gravity is 1.025 to 1.030. Proteinuria is considered more than 750 milligrams a day, and that's abnormal. However, if you have some in a febrile state, dehydration, or pregnancy, it may be normal, and it may or may not be significant. So things to know, drugs patients are sensitive to. A lot of times you'll see decreased effects due to decreased protein binding. Most opioids are inactivated by the liver, and some metabolites are excreted in the urine. With the exception of morphine and pyridine, significant metabolites generally don't occur. And those metabolites that stay around may lead to respiratory depression down the line. So as you start talking about volatile anesthetics, your ideal choice would be isoflurane. Ensure your potassium level is less than 5. Tricurium is degraded in the plasma by ester hydrolysis and Hoffman elimination, so it may be the ideal agent for intermediate range cases. Nimbex or cisatricurium is primarily Hoffman elimination. Vecuronium and rocuronium are renal excretion. And the prolonged effects of ROC in patients with severe renal disease may or may not be clinically significant. Pancuronium is metabolized by the liver and then it's excreted by the kidneys. And renal excretion is the primary route of elimination for reversal agents, so it'll be around for a little while. Tubular secretion are the movement of substances from the blood to the filtrate. About a fifth of the blood is filtered in the Bowman's capsule. Acute renal failure is defined as the sudden inability of the kidneys to vary urine content flow appropriately. This results in retention of nitrogenous waste products, also known as uremia or azotemia. Periop acute renal failure accounts for about half of the patients requiring acute dialysis. Acute renal failure is generally self-limiting. Chronic renal failure is slow and progressive, occurring over 3 to 6 months, but it's also irreversible. So think about that when you're considering acute versus chronic. Is this something that can be reversed? And it results in decreased in renal blood flow, GFR, and tubular function, reabsorptive capacity. So all those things lead to chronic renal failure. Prerenal failure is generally due to hemodynamic or endocrine factors that impair renal function. As a result, you get decreased renal perfusion pressure and increased renal vascular resistance. Causes include hypovolemia, hypotension, and decreased cardiac output. Causes of increased renal resistance or causes include increased renal resistance, clots, drugs, neuro or humoral factors. Renal failure is also known as intrarenal failure, related to parenchymal disease or damage, and it's generally caused by intrinsic renal disease, ischemia, or nephrotoxins. Post-renal failure is caused by urinary tract obstruction below the kidneys. Extrinsic factors may include tumors or inadvertent urethral ligation. Oliguric renal failure, urine volume is less than 400 mL per day, or intraop less than a half ml per kilo. Anuric renal failure is less than 100 mL per day. ATN, acute tubular necrosis, is produced by ischemia and nephrotoxins. In the initiation period, you have renal hypoperfusion, which leads to decreased tubular function, tubular obstruction, and sustained reduction in renal blood flow and glomerular filtration. During the maintenance period, you have renal vasoconstriction, decreased glomerular permeability, fluid filtration, loss of renal function, and finally kidney damage. Drugs don't work really well at that point. You're going to have dialysis. So you can treat it early on, but if it gets that far, it's very difficult to treat with just medications. Results in electrolyte abnormalities, increased potassium, decreased sodium. There's a recovery period, and if treated, you may have improvement in renal function over months up to a year, but generally after a year, it's permanent damage. About 50% of all cases of acute renal failure follow major trauma or surgery. The majority involve ischemia or nephrotoxins. Nephrotoxins are about 35%. You'll see the endogenous hemoglobin hemolysis, myoglobinuria, heavy metal poisoning, some medications, aminoglycosides, amphotericin B, and cisplatin. So think about all those medications that are going to impact your kidneys when you're giving them. Intrinsic renal disease accounts for about 15% of the diseases, so generally chronic hypertension or glomerulonephritis. Risk factors include decreased renal reserve, cardiac problems, major vascular procedures, long cardiopulmonary bypass time, and long procedures overall. Prevention and management: try and promote renal perfusion, keep your MAP and cardiac output up, identify high-risk patients and procedures, correct fluid losses and hypovolemia. Be aggressive if permissible, and make sure overall you're maintaining adequate hydration with adequate fluid calculations. Just keep an eye on this slide and remember some basic strategies for perioperative maintenance. Remember, onset precedes the actual injury, so if you start seeing the injury itself, you're probably a little behind already. When you start having major alterations in hemodynamics, you need to address them quickly or you will have long-term renal effects. So chronic renal failure is generally caused by glomerulonephritis, pyelo, diabetes, vascular issues, or hypertensive insults to the kidneys. There are also some congenital defects that will lead to that. Decreased renal reserve is loss of nephron function without symptoms. Renal insufficiency occurs when only 10 to 40% of the nephrons are functioning adequately. So if you think about that, it's a pretty significant insult when you start losing 40% of your nephrons. End-stage renal failure, uremia is loss of about 95%. So keep in mind that even though they are end-stage renal, they may have some degree of renal function. Just a couple other things we're going to talk about. Disequilibrium syndrome. The fluid follows the sodium into the brain. Reduced plasma volume may result in hypotension. Contributing factors are a decreased sympathetic response. And in these patients, make sure you're treating anemia if the hematocrit is less than 20. Just a quick overview of perioperative and preoperative renal assessment. A lot of times you won't see manifestations of uremia until the GFR decreases to less than 25%, so they've already had a pretty significant impact when your GFR is showing you that. And erythropoietin may aid in production of erythrocytes. These patients a lot of times will present with fatigue and weakness, or kind of the early complaints. It may progress to seizures, and they may develop increased levels of 2,3-DPG in response to decreased oxygen carrying capacity. So you may see monitored acidosis. They may increase their minute volume trying to compensate and blow off that carbon dioxide. Sodium and early renal insufficiency may result in sodium wasting. End-stage renal, you're more likely to retain the sodium. Ability to secrete magnesium reduced. Hypocalcemia is seen secondary to the inability to secrete vitamin D. Fatal dysrhythmias may occur with potassium levels about 7 or 8. A patient with end-stage renal, a lot of times you're going to see the serum albumin levels be significantly decreased, so think about the protein binding effects of your medications. IV fluids are best avoided in chronic renal failure, especially concerns over solutions with potassium. Though there's some decent literature out there saying that sodium chloride may also not be the best choice either. All right, just talking a couple procedures that we run into commonly for renal patients and associated with renal system. Cysto, big things to know. You can have injury to the common peroneal nerve due to dorsiflexion of the foot. If the lateral thigh rests against the candy canes or supports, you may have compression of that nerve. Rapid lowering of the legs decreases venous return, which results is, you may have a brief bout of hypotension. So if you see them drop the legs down quickly, you may want to wait a minute before you cycle up blood pressure. Cystos for children are done as generals. If you're doing a spinal, generally you want about a T10 level for excellent anesthesia for those patients. And remember that indigo carmine may cause hypo or hypertension. For TERP, one of the biggest test questions you run into talks about absorption of the irrigation fluid, and it's dependent on the resection time. So if you've got a long case with a lot of stuff, after 1 hour, consider checking your electrolytes, and you may want to switch to normal saline after 1 bag of sterile water. The other factor is that the absorption rate is kind of dependent on how high up the fluid is. Obviously, as your bag goes up higher, there's a higher pressure gradient driving that fluid into the patient. Again, if you're doing regional with these patients, subarachnoid block to T10 provides excellent anesthesia. And what you'll start to see in these patients as they get fluid overloaded is their pulse ox drifts down slowly. Just a quick overview of ESWAL stuff. This is done 2 ways. Generally, we're not using water baths anymore, but there are some places that do. So you can think about the logistical concerns of putting your patient under anesthesia into a bathtub. The other thing is it can be done as a general anesthetic. It's relatively uncomfortable, especially with the plates that are kind of driving the stones loose in those patients. So they want a little bit more than sedation. And then talking about radical surgeries, these can be fairly extensive procedures. And then moving on into renal transplant. And the best evaluation of good urine function after renal transplant is brisk urine flow. They may use mannitol to kind of give it a little boost there. And keep an eye on your electrolytes in these patients. A lot of them obviously had renal issues beforehand. Generally, at the end of the case, you're going to extubate them, and they may ask you to give the transplant cocktail, which is a combination of mannitol and albumin, kind of just to jumpstart the kidneys. And if it's a cadaveric kidney, they may use Latix as well. And just some quick references for you.